Welcome to Medical Specialists Associates Educational Series on topics in critical care medicine. I'm Christopher Voss, MD, MS, FCCP, board certified in anesthesiology, critical care medicine, neurocritical care medicine, and critical care echocardiography. Today, we will critically examine the use of central venous pressure, CVP, as a guide for fluid management in sepsis and septic shock. CVP-guided fluid resuscitation has been a long-standing practice in critical care, but emerging evidence suggests that it may be an antiquated approach that no longer aligns with current best practices. This talk will explore the limitations of CVP as a fluid management tool, review the latest research, and briefly discuss alternative methods that are now recommended for managing fluid resuscitation in septic patients. Background on CVP in sepsis management. Central venous pressure is a measurement of the pressure in the thoracic vena cava near the right atrium and has historically been used as an indicator of intravascular volume status and right ventricular function. The assumption was that a low CVP indicated hypovolemia, prompting fluid administration, while a high CVP suggested adequate or excessive volume, leading to fluid restriction. This concept was central to early fluid resuscitation protocols, including the Surviving Sepsis Campaign guidelines. However, over time, the utility of CVP as a reliable guide for fluid management has been called into question. The relationship between CVP and blood volume is complex and influenced by multiple factors, including intrathoracic pressure, cardiac compliance, and venous tone. As a result, CVP may not accurately reflect true intravascular volume status, leading to potential mismanagement of fluids in critically ill patients. Limitations of CVP in fluid management. 1. Poor correlation with fluid responsiveness. Evidence. Numerous studies have demonstrated that CVP does not reliably predict fluid responsiveness. A meta-analysis by Marik et al., 2008, found no significant correlation between CVP and changes in stroke volume or cardiac output following a fluid challenge. Implications. Using CVP to guide fluid boluses can lead to inappropriate fluid administration, either by giving fluids to non-responsive patients or withholding fluids from those who might benefit. 2. Static nature of CVP. Rationale. CVP is a static measurement, providing a single snapshot of intravascular pressure that may not reflect the dynamic changes occurring in a septic patient's cardiovascular system. Evidence. The static nature of CVP fails to capture the dynamic interactions between preload, afterload, and contractility, making it an unreliable indicator for guiding fluid resuscitation. 3. Influence of external factors. Rationale. CVP can be influenced by a variety of external factors unrelated to fluid status, such as positive pressure ventilation, abdominal compartment syndrome, or mechanical obstruction, e.g., tamponade. Implications. These confounding factors can lead to misleading CVP readings, further complicating the assessment of fluid needs. 4. Risk of fluid overload. Rationale. Over-reliance on CVP may lead to unnecessary fluid administration, contributing to fluid overload and its associated complications, including pulmonary edema, impaired oxygenation, and increased mortality. Evidence. Studies have shown that positive fluid balance, often driven by CVP-guided fluid boluses, is associated with worse outcomes in septic patients. Current best practices in fluid management for sepsis and septic shock. Given the limitations of CVP, current guidelines and expert recommendations have shifted towards using dynamic assessments, bedside echocardiography, and other more reliable methods for guiding fluid resuscitation in sepsis and septic shock. Conclusion. The use of central venous pressure as a guide for fluid management in sepsis and septic shock is increasingly recognized as an outdated and potentially harmful practice. The static and unreliable nature of CVP, along with its poor correlation with fluid responsiveness, has led to a shift towards more dynamic and accurate methods of assessing fluid needs. By adopting these current best practices, critical care providers can improve patient outcomes, reduce the risk of fluid overload, and provide more precise and individualized care to septic patients. To learn more about critical care medicine, please visit us on our website at www.medspecialists.net and subscribe to our YouTube channel.